Brief from, brief from NITRE, ENITI, Nurses' Efforts to Eliminate TB in India. I am Shima John, moderator for this eco-clinic. Here in this clinic, interdisciplinary team of specialists meet with learners in sharing best practices and applying case-based learning to improve outcomes. We have our own flexible learning classes where we easily discuss the insights and challenges in the nursing field. This time, we have sent joining links to ETTI members too. End Tuberculosis Transmission Initiative, covering airborne infection, prevention control. It's a working group of Stop TB partnership aimed to support the global fight against TB and other airborne infections by promoting development and implementation of feasible measures able to prevent and control the airborne infection transmission. Special welcome to all those who are from ETTI. And now for the information of newly joined. This is our 16th ENITI clinic, and we conduct this clinic every Friday, last Friday of every month. But this time we preponed this session due to unavailability of experts on that day. We distribute certificates after the session. So those all who require certificates for this clinic, kindly join separately using your email account and not in a group. Only then you will get your certificate. Initially, this clinic was for nurses from our institute. But later, after the official launch of this ENITI, we have made this clinic a public. And we have, with a view to share and expand the knowledge with a vision to involve other institutions as learners as well as presenters. I hope our ENITI with chain of sessions will help you grow and become more productive and as smarter than your present capacity. Well, I welcome again each and everyone present here. Before we start the clinic, let me introduce our dynamic team here. To my right is Dr. Anita Rani Kansal, our nursing superintendent from NITRE. Ma'am has been a master trainer for training of nurses in TB by ICN and has been recognized by ICN TB MDR TB project as a leading light in recognition of her outstanding contribution to care of people with TB. Welcome to this session. We have our expert with us online, Miss Barbara Wokanen. Miss Barbara, ma'am, is HVAC engineer with 12 years of experience in designing ventilation systems for TB facilities and consulting in the field of TB IPC, environmental measures, in Eastern Europe and Central Asia. Since a year, she has been a core group member of NTB Transmission Initiative, Stop TB Working Group. Welcome you, ma'am, to this session. Now, our next expert is Grigory Volchenkov. Sir served as Chief Doctor at Vladimir Regional Tuberculosis Control Center in Vladimir, Russia since 2002 and retired in November 2022. Dr. Volchenkov managed to successfully implement comprehensive TB PC programs in TB control services of Vladimir region. Sir organized and participated as facilitator in several international BSc certification training courses in Vladimir, Russia. Dr. Volchenkov, currently an independent TB and airborne IPC consultant, is chair of NTB Transmission Initiative, that is ETTI, working group of Stop TB Partnership. Sir serves as TB IPC expert for regional GLC of WHO. We welcome you, sir, to this ENITI clinic. Welcome you, sir.
Good afternoon, good morning. Thank you for inviting. Thank you.
Good afternoon, sir.
Thank you, sir. Thank you for joining.
And now the third expert with us is Dr. Paul Arthur Jensen. Dr. Paul Arthur Jensen is an independent consultant in the areas of engineering controls, airborne infection prevention control, and laboratory biosafety. Dr. Jensen is the co-founder and chief engineer of Final Approach INC and shares his expertise both domestically and internationally. Dr. Jensen serves as the Secretariat of the NTB Transmission Initiative of the Stop TB Partnership and continues to serve as several IEC, ICS, AHA committees. On May 2020, Dr. Jensen retired from the US government after a total of 33 years with the US Centers for Disease Control and Prevention and 10 years with the US Coast Guard. Sir has extensive experience in sampling and analysis of bioaerosols, design and evaluation of ventilation systems and UVC systems, control of airborne Microbacterium tuberculosis, and evaluation of respiratory productive equipments. He collaborated regularly with WHO and many international partners. He has umpteen number of publications to his credit. We welcome you, sir, to this clinic. Welcome you, sir.
Thank you. Happy to be here. Thank you for the invitation.
Thank you, sir.
Thank you.
Thank you for joining this clinic, sir. And we have with us a special invitee from our institute, NITRD, Dr. Sanjay Gupta, HOD, Head of the Department of TB and Respiratory Diseases. Sir, we welcome you to this clinic.
Thank you.
Sir, we would like to say a few words for this clinic which is going on.
Okay,
Would you like to share some words from your side? Okay, sir, just.
I have unmuted myself. Welcome to all the experts for this program and all the participants. This is I can see there are more than 100 participants for this joining in this webinar on ENITI platform, and the topic is very good, the airborne control measures and infection control measures and environmental controls. I think it's a very relevant topic, and we have very good experts, so let us not waste time and start the the webinar. Thank you.
Thank you, sir. Thank you so much. Thank you so much for your words. Along with him, along with Dr. Sanjay, Dr. Rajesh is also there. He's also from our institute. He's Chief Medical Officer from our institute. We welcome you too, sir.
Thank you. Thank you so much.
Thank you. Thank you for joining. Well, now, before going to the class session, I request all the learners and participants here to mute their microphone so there is no distractive noises. And you can unmute when you want to speak out or when you want to ask queries. And keep patience. If there is any unexpected outcomes like technical errors or interactions, please bear with patience. Kindly do not do multitasking and keep focused on the session. On to Dr. Anita Rani Kansal. Ma'am, please start with your session. Excuse me, we have with our to my extreme right is Miss Sakshi Arora. She's the coordinator of our continuing nursing education. We welcome you, ma'am, too. And in my extreme right is Madam Simran. She's senior nursing officer, and she's also a team of equity.
Violet also, senior nursing.
Okay, ma'am.
Okay. Thank you, Shima, for introducing all of us. And today, I think it's very important day and very good day that you have so many experts in this field. Because I will be keeping just it a very simple, because this will be going to nurses who are working practically. So it will be just for those nurses who are not knowing anything about the airborne infection control. And so it will be very simple in very simple language, so that at least you get something to know that how you can make your environment better in your practical working settings. So because this is the third webinar in the series of airborne infection control, we have covered last two webinars on the basics of airborne infection control and the administrative controls. In that, we covered what is TB, how it is transmitted, what are the cough dynamics, what is ventilation, how we can reduce the bacteria in the air, what are the air changes per hour, what are the methods of airborne infection control, and what are the administrative controls, how the administration can take the steps to have a good airborne infection control in any healthcare settings. So today's session, this is the third webinar, as I said. So we will talk about the airborne infection control, but on the environmental control, that what changes we can make in our environment so that we can reduce the concentration of bacteria and we can make it a safer air environment for us. So what is environment control? That is aimed at reducing the concentration of infectious droplet nuclei in the air. So basically, we will be concentrating on the ventilation system. That any nurse, I think that I have covered in my basics of TB also, any nurse or any healthcare worker who is posted, they must look at that from where the air is coming and from where the air is going. And what is the air changes? Like, is it adequate? It is not. And the direction is also important. So these two things, that what is the ventilation and how many, whether this ventilation is adequate, that every nurse, if she enters any room, I think they should be able to see this question in their mind, whether the ventilation is adequate and whether this is good or not. So what are the last slide, please? So there are mainly three ventilation systems that we see. That is the natural ventilation, and then we have the mixed mode, and third is the mechanical ventilation. So we'll talk one by one. So first is the natural ventilation. Next slide. So this is the simplest form of and the least expensive technique, in which we just say that there should be adequate windows where the air can pass through. Like you can see in this pinpoint. You can see in the single-sided ventilation. This is a single-sided ventilation, that the air changes are there, but that is not that much. In the cross ventilation, you can see the windows are at the opposite side from where once the air comes and goes. Then the stack ventilation, where we have the ventilation from all sides. So this is the natural ventilation, is maximizing natural ventilation through open windows, open shaft, and bed spacing. There should be adequate bed spacing between the two beds. Next. So this is just an example of, this is the picture of our OPD, where this shows the example of stacked ventilation, where we have the doors and windows at the four sides of the OPD, and plus in between we have this major, you can say major outlet from where the air can come and go. So this is an example of the stacked ventilation, but the direction of the air is also important. Where the physicians are sitting and where the patient's waiting area is there, that is also important. The next picture, that is one is picture at the upper side is that we are showing the bed spacing, that how that should be good, at least 6 feet between the two beds in any infectious or even non-infectious setting also. So that I was saying, the adequacy of the ventilation, and then the direction is also. This slide we covered in the first seminar also, that what is the direction of natural ventilation. That healthcare, you can see in this, the green is the healthcare worker. That green dot is healthcare worker and the blue dot is patient. So if the wind is flowing from the healthcare worker to the patient and then it is coming out, that is a very good method. Then bad is, because in the natural ventilation, you cannot control the direction of the wind. That will move in whatever environment or at the pressure gradient will be there. So in this case, in the second, this thing, you can see that the wind is coming from the window. It passes first the patient, then the healthcare worker, then it's coming out. So that means the infected wind from the patient, it is going to healthcare worker, then it is coming out. So this is not a good method of direction of air. Then we have a third portion also. We have a third portion also, where this is a good compromise, where the healthcare worker is at one, if it's not possible, and the patient is at the other side and wind is crossing, at least some ventilation is there. Next slide. So what are the limitations of natural ventilation? That one thing, we cannot control the direction. Second thing, in India, like we have a extreme weathers in the June, or like now today's temperature is 45 degrees. We just can't make, because that air will be very hot. It will be very difficult for the patient to stay in the wards with open window where that hot air that in India we call it loo. So that patient they do not prefer, and we cannot make the patient to stay in such a hot environment. Or same as in the extreme winters, when it's in December or January, the winter is very harsh and we cannot keep the windows all the time open at that time. So this is the one drawback of the limitation of the natural ventilation. Then we have a mixed mode ventilation, like we can use the exhaust fans. We can at least give the direction to the air. We can keep the one window open at one side, and second we can keep the exhaust at the other side. So that will make at least some way that we need not to open all the windows. At least one window is open. That will help in some of the better ventilation and air changes. So what are the limitations of mixed mode ventilation? That usually improper installation of the exhaust fan. People do not know where the exhaust fan has to be installed in that particular room or in that facility. Then the size of exhaust fan, because it has to be calculated whether how big the room is, what is the volume of that room, how big exhaust fan with what speed it is needed. That most of the people, they are not aware of it. Then maintenance and mesh cleaning. Usually in India, we have seen that the fans or their like they will get so much of dust that it will impact the air changes. So this is just an example of that improper installation of ventilation system, that is exhaust fans. It means whatever air is coming from the window, that is being exhausted by the exhaust fan. So ultimately there is no change in the room air. So what is important is that the room air has to be changed. Just putting an exhaust fan is not important. What is important is that how we can change the air of that room. So sometimes it's better just to open the window instead rather than putting this. So this problem we have faced even in our NITRD also. So we have kept the posters in our wards that you have to keep the exhaust on with the opposite window open. It's the same just window just near below the exhaust fan, that should be closed. So this type of posters or education that we have posted in our wards so that everybody knows it. So this is again an example of just putting the exhaust fan or the fan so that it will keep on rotating but will not help in the air change of that room. This is just a small study. It was done about how the exhaust fan or the mesh cleaning that gives the impact on the air changes in the female ward in a tertiary care. This was done after I got the training from CDC about the airborne infection control, and we had one very good staff nurse at that time, nursing officer with us, Ashima Arora. Today she is with us. I'm very happy to see her. She did a lot of Ashima did a lot of work on this, and we published this small paper by nurses in our NATCON in 2016 or 2018. I think we published this small paper. So this was just a nurse's effort that how air changes can be improved with just mesh cleaning. So thank you, Ashima. She must be here somewhere here. I have seen her. Next. So this was just a poster presentation that we did where we are measuring the air changes per hour and then before cleaning and after cleaning of the mesh in one of the particular ward of NITRD. This is mechanical ventilation, the use of negative pressure to control. In this, totally, you do not allow any air from outside by the natural ventilation, but you make the air to move in particular direction with the help of creating negative pressures. That we have in our 2 MDR wards. We have 2 multiple drug-resistant wards where this type of mechanical ventilation has been created for the indoor MDR patients. So these are the principles behind mechanical ventilation that you here see the in and the out. You can see in the nurse's room, the in pressure is more and the out pressure is less. As we go to the veranda or the in-between space and then to the patient space, you can see the in air is 200 meters square per hour and the out is 225. That creates a vacuum that creates a negative pressure so that the air will move into that direction from the nurse's duty room to the patient room, and then it will be expelled out. So what are the limitations of mechanical ventilation? That one thing, it is very, very complex because you need to have a control and maintenance that becomes very costly, number one. Number two, some dedicated people are needed to maintain that. And this is very costly also, that we have a 2 MDR wards where we have a 24 beds, and we are paying monthly maintenance in lakhs just for these 2 beds, which accommodate only 24 patients, where we have so many of patients that we cannot keep in these MDR wards because we don't have that many beds. Next. So other thing that in addition to this, there was a ultraviolet germicidal irradiation. That is that we can kill the bacteria within the air by using this UVGI. So in high risk setting where it is not possible to achieve the adequate air changes using natural ventilation, a complementary option is to use the upper room or the shielded ultraviolet germicidal irradiation UVGI devices. Installation should seek to irradiate the maximal air volume with the highest intensity while keeping the staff and the patient safe. I can see Paul here. So Paul has helped with the help of CDC. They have installed almost more than 50 UVGI in our hospital, and they have taught nurses and engineers how to maintain it and how to take care of it and how to utilize it. So there were so many issues related to this that I'll come to this. So this was just to augment the environmental control and augment in the series of reducing pathogens in the air. So this is a picture of our OPD where it has been posted in the patient waiting area, where it has been installed at the patient waiting area. Next slide, please. UVGIs are less expensive alternative to the other expensive measures, and with the help of CDC, we got it in free, that so that we can have a better infection control. So this consists of special lamps that gives the ultraviolet light, and it must be installed in the upper part of rooms or the corridors, and or should be placed in the exhaust ducts. This is particularly useful in the larger wards or TB clinic waiting area. So limitations of the UVGI, first thing is acceptance. Acceptance was very, very tough among the staff because they thought that it can create some form of side effects to the staff or can cause cancer or like that. So there were so many views. So making the people understand that how we can make it safe, that was an challenge that we faced, and ultimately we made the staff to accept it. Then installation. Of course, installation was done by Paul and his team in our hospital. Then radiation exposure, it has to be measured regularly at the three months or something like that. So this is not good for small wards, and the regular maintenance and change of lights. So because when you get something and you are not, so engineers and other people, they have to be given the responsibility, or the infection control nurse with the SOPs, that how it has to be maintained, when the lights have to be changed, who will be changing it, who will be purchasing it. All these logbooks and records need to be maintained, which becomes very difficult in any government setting. The maintenance of records like the logbooks, when it was installed, when it was cleaned, who has cleaned it, all these things. And it required separate staff or dedicated staff to maintain all this. So this was covered in the administrative control also, where the administration takes the call that the TB and the non-TB wards should be separated, HIV or the TB ward should be separated like this. So this is for the nurses, that how they can put, if because always it is not possible to separate all the TB MDR patients in separate wards, because we have our own constraint. Sometimes we have to put the TB patients, MDR patients, and HIV patient in one ward only, because we don't have that many facilities, or patients load is very high. So this is just for the nurses, that how they can make it what is the risk transmission is there. So HIV negative, so this is the maximum risk will be. So this is the, if the HIV negative, HIV positive, there will be low risk. If the smear TB positive and HIV positive, that will be risk. That you know, because the HIV patients, they are usually immunosuppressive and they are likely to get TB very fast. And then MDR TB and the HIV positive, that is the greatest risk. So this accordingly the nurses can plan where to allot the beds in the wards accordingly. So these are some of the practical implementation at the NITRD: exhaust fans and the maintenance and monitoring, UVGI installation in OPD, bronchoscopy, X-ray, because these are the closed areas, and well ventilated wards, exhaust fans, spacious wards, and UVGI. So this is an example of, this is picture of MDR ward in our hospital, which I told there are two wards. This is 12-bedded ward with the unidirectional airflow with negative pressures. We have 12 rooms, each with separate negative pressure. And we have a logbooks and monitoring attached. The shift nurses in each shift, they maintain the logbook, what is the pressure of each room and what is the pressure of corridors. And MDR patients are admitted here for the initiation of the treatment. And we have the CCTV so that she can monitor all the 12 patients. She can monitor by sitting at the in her duty room. So bed arrangement, positive cases near the big windows. Then monitoring and checking of air changes per hour. Just to summarize that, what we nurses can do so that we can have a safer environment for themselves and for patients, that we can have our patient segregation. We can see which are positive patients, sputum +3 +2 patients, they can be segregated away from the those who are on the treatment and negative patients. Then bed spacing, ensuring effective ventilation at all time and seasons. Special attention for the high-risk areas such as X-ray, bronchoscopy, or aerosol generating spaces. Then designated wards for infectious MDR patients, adequate air change, air direction, installation of UVGI, and high-risk setting should be prioritized for immediate assessment. And I think our experts, Paul has done a lot of training in our institute in India, has done a lot of work in UVGI, has installed UVGI in our hospital. And I think Barbara is a special engineer. So they will be able to augment my session and can take up the any doubts that nurses have. Thank you so much.
Thank you, ma'am. It was standout presentation from you. Language was very simple, and I think even a layman could understand what you said. In a very, very simple language. Thank you, ma'am. Thank you. Over to experts, Barbara, ma'am. Ma'am, we could highly appreciate if you could take a moment and tell us if there is any area where additional depth or explanation may be beneficial for us. Any area. Any slide which you think is you have to go little more depth. Miss Barbara, ma'am, are you there?
Or Paul can see.
I can I can say first good day everybody. Thank you, Anita, for your presentation. Actually, it's just 30 minutes. It's very fast because usually for environmental controls we have like whole day because it's big topic, it's technically, but okay, we have just 30 minutes for presentation and 30 minutes for answers. And what I would like to very fast to say, firstly, that me, Grigori, Paul, and Anita, we are from NTB Transmission Initiative, and I put information to chat, to our chat. We can very fast have a look. Actually, you can visit our website, subscribe to our newsletter, and we have a lot of information about
Airborne infection.
airborne IPC. And of course, you can write us and to ask question later, for example, if you have, so you are welcome. And if you have some questions, for example, I can answer about ventilation, and Paul also, because I have more experience in mechanical ventilation, but I assume that in India mainly use natural ventilation. Yeah, and about UVGI also Paul and Grigori will answer.
So shall we move to Dr. Grigori Volkentov, please? So if you would add any constructive points and insights to further enhance the depth and quality of the discussion of ma'am's presentation. So would you like to add on any constructive points?
Yeah, Anita gave very fast and comprehensive presentation. Covered huge area. And this area is extremely important to control TB transmission. TB is a very specific infection. It transmits through the air. So we have to create safe air around patients, around visitors, around healthcare workers. And I would like to clarify a little bit on UVGI use. When we are talking about controlling airborne transmission of COVID, TB, other airborne infections, we are talking about upper room UVGI. It's about disinfecting air under the ceiling and creating highest concentration of UVGI up in unoccupied area of the room and making safe environment for patients, staff in the lower occupied area of the room. So we should every time think about upper room UVGI, because whole room UVGI is for disinfection of surfaces and objects. So it's more about the controlling transmission of contact infections. So when we're talking about the airborne infections, we have to talk about upper room UVGI, and the fixtures Anita demonstrated are about exactly upper room UVGI. And the second thing I would like to stress is the importance of risk assessment. When we are making adequate TB transmission risk assessment or COVID transmission risk assessment, we will be able to implement available environmental controls and make them most effective in our settings. And it will eliminate the risk, and unfortunately we have no absolutely effective environmental controls, 100% effective. And because of that, we need, in some cases, in many cases actually, also personal respiratory protection. And the next webinar, as I understand, will be dedicated to personal respiratory protection, which is also very important. Thank you, Anita, Rani Kansal, doctor, for such wonderful session for Indian nurses.
Thank you, sir.
Thank you, sir. Next time I'll try to be a little slow.
Now we move on to our third expert here, Dr. Paul Arthur. Sir, any overlooked aspects or angles that you would enrich ma'am's analysis? Any points you want to add? Any idea? Yes, sir, carry on.
Yes, first I have a few points to make. First is thank you, Anita, for an excellent presentation. I thank all the nurses here because you are the ones who are in front of the patients. You take care of the patients, and we as infection control specialists want to make sure that the patients are protected, the staff are protected, and the public are protected, as Grigori mentioned. I also thank Dr. Sarin and now Dr. Gupta for their support in enhancing the infection prevention control program at NITRD. I've enjoyed many years visiting and helping and consulting with them. I use NITRD in many of my presentations as examples of the progression of infection control measures. I've used them pictures and talked about different parts of the NITRD where things worked very well. So, NITRD is known internationally as well. From the standpoint of adding one comment to the whole lecture, is when we implement any kind of airborne infection prevention and control, we need to make sure we understand the sustainability issues. They were briefly mentioned by Anita, but sustainability means many, many things. It means having the budget for maintenance. It means having the knowledge within the staff so that you can say, okay, yes, this contractor came in and did it correctly, or they did it incorrectly. For example, in the MDR-TB ward, are the rooms actually negative pressure or not? That's the responsibility of the nurse to check to see, okay, yes, the rooms still are negative pressure. And if not, there's a procedure for reporting it. But if that ventilation system is not maintained, or there's not a way to get it repaired in a timely manner, then it's not sustainable. And as Dr. Anita mentioned in one of her early slides, sometimes it may be better to do nothing than to modify or develop a whole system, ventilation system. And I've been in other institutions that had a very well-designed, naturally ventilated building. They sealed it up, added mechanical ventilation, usually with cooling and sometimes heating. And then it broke down. So now they have a building that's very tightly sealed with no air movement. So in that case, it really was not sustainable for that. And the second point from the standpoint of sustainability is understanding education. That was also mentioned here. Do the staff and patients understand what you're doing and why? So those are my major comments. And again, thank you.
Thank you. Dr. Sanjay Gupta, sir, can you bring out any idea?
Can I add to
Dr. Sanjay Gupta is there? Yes, sir. Any ideas for any practical application in the real world implication of the case? Sir, any slides? Ma'am,
I
maybe
think the lecture taken by Dr. Anita was very good, and basics पे ही ज़्यादा उन्होंने वो किया हुआ था अपना, तो I think it will be very helpful, and just keep it up and let us see हम अपने wards में अपने hospital में कितना कर पाते हैं इसके लिए.
Thank you,
At
sir.
least in the new buildings we will be these will be very helpful. These environmental controls, we will try to keep them. All these follow all these controls in the new buildings. It is sometimes difficult to follow these in the old buildings, but in the new buildings, of course, we will be able to do it. I hope it is the discussion, etc., is very helpful to all the participants. The total participants have increased now to almost 140, so it's good. Thank you very much.
Thank you. The three of the experts, is there any other thing you apply in your setup which we don't do in India? Dr. Paul from USA, is there anything else that you apply, any innovations which you apply in your country setup that we don't have in India here right now?
No, I mean, I think NITRD is a model facility because it actually has implemented most of the environmental controls available. The only criticism I would have is that it really needs to be promoted more so that people can understand that in certain situations natural ventilation works best there. In other cases, it's required to go to the higher level mechanical ventilation. So again, I just think it needs to be promoted more, and through the nurses is a great way also. Over.
Thank you, sir. Thank you for your time and expertise. Now we are moving to the open house discussion. Well, your questions, audience, participants, learners, your questions and perspectives are invaluable for making this class really engaging for everyone here. Kindly ask questions if you have any queries, you can ask here.
May I raise one issue, actually a couple of issues. Anita have not touched the room air cleaners for infection control.
Yes.
Very important thing to discuss now, maybe. And the second thing about air conditioning and airborne transmission risk.
Yes. Yes, I could have included air cleaners and the effect of air conditioning on the ventilation, that how, yeah. That I'll cover in the one slide in next presentation, that how they impact at the airborne infection control.
Yeah, I mean, I hope everybody understands that air conditioners do not provide any fresh air.
Yeah.
They do not provide any air change in the room. So usually people, when they start using air conditioner during hot weather, they block any natural ventilation available. So in fact, it maintains the higher concentration of bugs in the air. So it's artificially created higher risk conditions. So it means that when we experience comfort, we may experience higher risk of transmission of airborne infections, including TB. Air conditioning become very common in our countries. And now hot season in India. And I imagine maybe half of the Indian nurses now participating, they are staying in the air-conditioned rooms.
Yes.
So it may be very actually dangerous if the source of the infection exists somewhere around in the room. So we have to take care of implementing something else, maybe adding some natural ventilation, using respirator, adding upper room UVGI or whatever. And the second thing about room air cleaners, I would like to Paul to a little bit elaborate on this.
Okay, thank you, Grigori. And we, including Grigori, have done a lot of work evaluating room air cleaners. And in general, most of them do very little. Some have very low airflow rate. They're very expensive sometimes. They have very low airflow rate, so they clean just a tiny bit of air. They also have to work within the room, which means it has to have enough speed of the air coming out so it mixes the air within the room so it can clean the dirty air. And then many are very noisy, so patients or staff will turn them off. They take floor space, so they may move around, or people put books or other things on top of them, or put them under the bed, and then they don't become useful at all. So in general, room air cleaners are not recommended. In a few cases where you have a nice high flow room air cleaner that's designed properly, then yes. But most of them that are sold on the market are not good at all. And one other thing that's been promoted in India, I don't know if it's still being promoted, but 3 or 4 years ago, there was a group that was promoting this bactericidal paint on walls. And that's great if you have something that something meaning airborne bacteria that lands on the wall, and that the wall is clean enough and there's enough of that biocide in the paint to inactivate. But in general, it does little, if anything. Over.
Yes, thank you, Paul. This air cleaners, actually, in India, when we had a lot of pollution level issues in Delhi, then most of the people were buying it. But our institute, usually, whenever we had a class or anything on this, usually it was that it is of no use. So I think I could have covered this in better, saying that this is not of a very good use, that air cleaners. And AC also, that because this takes the recirculation of air. So like we have the buildings with fully AC, even if in one room there is any infectious patient or he has coughed bacteria, so that will keep on moving, that air is being circulated at the same time. So that's the problems with the like air conditioning and the combined air systems.
Thank you, Paul, sir. Thank you for adding this point. Let us all ponder on it. Now, for the audience, it's an opportunity for us to collectively explore the complexities of this case and gain a deeper understanding. Any questions from your side?
Yes, please, participants, you will not get this opportunity to ask to such an experts are available today. So it's opportunity to ask your questions.
Ma'am, what would be the other cleaners we can use in our hospital?
Any other cleaners that we can use? Like Mr. Paul, he mentioned that we can use that paint. In one OPD wall, I think they have done also, but we could not see any utilization or anything. Can Paul sir, can you elaborate on this? What are the other methods that can be used in our wards for better airborne infection controls?
I think with adding on the room air cleaners, which again have limited use, you've covered everything. You know, the go-to for number one would be the natural ventilation with good cross flow natural ventilation. You know, secondly would be adding some kind of mechanical ventilation, but with mechanical ventilation you need comfort. So if you're, you know, pushing 40, as you mentioned, 45-degree air into a room that's very small, you have the heat from the person and maybe some equipment, and they'll get super hot and uncomfortable. And then people will do things so that the ventilation system does not work. And I know you've seen, and I've seen in different locations where people block off, you know, exhaust grills or supply grills and cause the ventilation system not to work well. In many cases where there's limited resources, you know, the addition of UV works well. For the, you know, countries that have a lot of resources, UV works very well. So I think you'll find that may be a more common intervention. And just one last thing, which is a little bit of promotion for ETTI, is on the website that Vivara put in the chat. There's a document there about UV maintenance, and you may recognize some of the pictures there because a lot of the information there was taken from the efforts of implementing UVGI in NITRD. Over.
Thank you, Paul, sir. Now, audience, please don't hesitate to unmute your buttons and raise your questions. Any more further questions? If you are hesitating, please type your questions in the chat box.
They ask so many questions when TB case presentations are there because they know about the TB, so they ask so many questions. But airborne infection control is like a new thing that they are seeing. So rather they're grasping this rather than asking. So I think you should be asking if you have any doubt.
Remember,
But
yes, carry on.
yeah, thank you. But maybe we can discuss a little bit natural ventilation, and maybe Paul will add also something, because in my opinion, we can use natural ventilation, and especially in India, because it's warm and it can be highly effective, but just in well-designed buildings. And for example, in my opinion, well-designed buildings where we can use cross natural ventilation, because if we open windows or window and door from opposite side, then it will be direction of air, and we can actually receive a good air change. But for example, in my opinion, well-designed building where we can use natural ventilation, it's when is just room, one side room with opposite windows, or for example, corridor, open, for example, corridor, and when rooms from one side. So you can open windows from one side and doors. But maybe Paul can add also, in his opinion, what is what should be well-designed buildings to use natural ventilation, if very
no,
efficiently?
Yeah,
Yes, Paul,
Vavar,
you can help us because our hospital will be having master plan now, and this all will be abandoned now, and it will be a new building with 10 to 15 stories. So if you tell something so that if somebody asks us, we can contribute to in that.
yeah, the biggest question to ask when deciding whether or not natural ventilation is sustainable is to ask what happens when it rains or during the monsoon season. Because a well-designed building, and Vivara introduced the idea of a well-designed building, should be able to have good cross ventilation in good weather and in bad weather. So in good weather, it's not an issue. In bad weather, when it's raining and windy, we want to keep the rain from coming into the room, and we want an ability to close at least part of the opening, because the velocities would be so high, you don't need the whole window open, which would be uncomfortable for the patient. So patient comfort, again, is critical for natural ventilation. So just opening windows, in my mind, I don't call that natural ventilation. I call that, perhaps, maybe, sometimes natural ventilation, but it's not sustainable ventilation to protect people all the time. So again, when you're designing, we need to take a look and see, does the natural ventilation perform well all season long, all year long? Over.
Thank you, Paul, sir. Now back to audience. Any questions? So remember, there is no wrong questions or ideas. Every perspective is valuable. Kindly share your questions here. It will help us uncover new knowledge in us.
Ma'am, is there any floor cleaners or something like that that can generate air infections?
Generate or kill?
Do you want to say generate or kill?
No. It's if there are fumes or something like that that can generate infection, airborne infection.
Fumes.
Fumes.
See, if when you're working on patients, like you're suctioning the patient, bronchoscopy suits, there are chances that the aerosols will be there, and that will come into the air in more amounts. This is what you want to ask. So these are some of the areas where the aerosol generation will be there, and we will have more bacteria in those particular areas.
I think WHO does not recommend using aerosols, disinfectants in aerosols, to control the airborne infections, because we are talking about the using environmental controls while patients, staff, and visitors are inside the room. So it can be more dangerous for their health than for the bugs in the air. So it's not included into WHO recommendations to control TB transmission and other airborne transmissions. So recently, during the pandemic time in Moscow, they disinfected squares and streets in the Moscow. It didn't stop transmission of COVID. So we have to think about the effective interventions. And for environmental controls, the ventilation, upper room UVGI, sometimes air cleaners. There was a question in the chat about isolation or ventilation in the children's ward, TB ward. And it's about having good administrative control program, and environmental control should be based on good patients, diagnosis, separation, isolation, and so on. Which kids should be isolated, contagious. So we have to have confirmation of diagnosis, the severe status, and the treatment status. And very few kids needs isolation, only contagious kids for a very short period of time. When we start treatment, usually the contagiousness period stops very fast. So it means only isolation for the contagious kids, and other children in the TB ward should not be isolated.
Yeah,
So
I
in
think
the
you had 2 points.
Thank you.
yes, we
I'm sorry.
good
Thank you.
AC and good ventilation.
Thank you, sir. Can you share questions from chat box here on screen so that we can read out? I think there are no more questions.
And I'll just add 2 things to what Grigori said. One is that whatever you would do would be based on the risk assessment. And Grigori mentioned a few things that would have been included in your risk assessment to help you prioritize what, if anything, you would do to enhance. And well, that's the major point. Over.
There's one question in the chat box, whether the use of certain plants to help with environmental control and fresh air. So I think there's a lot of plants, not a single one. What do you say? The green plants, of course, help with environment control.
No, I think if yeah, anybody can answer. Paul sir can answer about this, that how the plants can help in.
वो पालन का काम हो गया हाँ, वो लेके आना एक और पालन भी ले जाना वो छोड़ देना मैं दोबारा से करवा दूंगी दूसरा वाला कमरे का किसी को बुला लो
Somebody is asking about the certain plants to help the environmental control and fresh air.
I do not have any idea about any evidence of the effectiveness of plants against airborne infections. Maybe it will be published somewhere someday, but currently WHO does not include this into the effective environmental control interventions to stop transmission of TB.
Okay. Thank you. Thank you, sir.
Thank you. Any more questions?
Any other questions?
Okay, no more questions in the chat box. Any more questions? See, your inputs will enhance your knowledge only and ours too. So please ask questions so that this becomes an interactive session.
If anyone wants to add anything, they are welcome. Otherwise, we are about to close this meeting. Just 1 minute more.
When no more questions, we have come to the end of the session. Thank you all for your active participation. My sincere gratitude to all those who have joined in this clinic. I extend my special thanks to all the experts here who have joined, who given us their special time, their valuable time to us and joined. And
from 7 seas.
From overseas. Their valuable insights and expertise they've shared with us. Thank you for that, sir.
Feedback.
Well, before we conclude, please feel free to give your feedbacks too.
You have to give your feedback so that it helps us to improve.
You'll receive a link.
You'll receive a link for the feedback.
Please
fill. These are 2-3 questions.
There's 2-3 questions to fill and give your feedback. We will be able to know. Yes, sir.
Thank you, Dr. Anita, and special thanks to Paul Jensen, who joined us in the middle of his night in Florida.
Thank you. In the middle of night, really. Thank you, Barbara. Thank you, Paul.
Have a wonderful day, all the experts, and
have a good night. Good night to Paul.
Okay, good night again. Thank you. Bye.
Thank you. Bye.
Thank you, sir.
We'll keep the session running for another 1 minute. Till then, the link of the feedback in the chat box. Please give your feedback. Give the next.
Sifa, can we go for close?
For 1 minute for feedback only.
Okay, okay.
participants.
Thank you.
संजय गुप्ता पूछ रहे हैं नहीं नहीं संजय गुप्ता का नहीं अच्छा
Participants who have shared their feedback can leave the session. We have concluded the session. We will just keep the session running for another 1 minute so that you all can give your feedback. The feedback link is in the chat box. Please click on the link and share your feedback. Okay. We'll close the session another minute. Thank you.
नहीं देना ना तो